Hello, everyone. It's my pleasure to welcome you today to Susan G. Komen's virtual MBC Impact Series event. My name is Casey Volpe with Susan G. Komen's Community Education and Outreach team. The programming for the Impact Series is envisioned as a year-long conversation with attendees, presenting new information and speakers each month. Today, our important conversation focuses on advances in MBC research and technology, and our speaker will be Dr. Nancy Lin with the Dana-Farber Cancer Institute. Moderating today's event is Elizabeth Frank, a fierce MBC advocate. Before we begin, Komen would like to thank our sponsors for supporting the 2022 MBC Impact Series. Thank you to AstraZeneca for being the technology sponsor for this year's event series. This virtual setting means that MBC patients, no matter where they live, can be part of this community. We would also like to thank our premier sponsors, Amgen and GE Healthcare, and our signature sponsors, Walgreens, Daiichi Sankyo, Sanofi, and Merck. The series is made possible because of the generosity of these sponsors. One more quick housekeeping note. While our speakers are talking, please feel free to post your questions in the Q&A feature in Zoom, and we will get to as many as we can after the presentation. Towards the end of our programming, a survey link will be placed in the chat. Your feedback is very important to us and very helpful for future MBC programming planning. By completing the survey, you'll be entered into drawing to win an Amazon gift card. Now, we are very excited you're joining us today, and I would like to get us started by introducing Liz Frank. Liz is an 18-year breast cancer survivor and patient advocate focusing on stakeholder engagement and medical research. Liz's current activities include co-creating a website for breast cancer patients whose cancer has spread to their brain, mbcbrainmets.org, leading the advocacy core for a large phase 3 trial for patients with DCIS, and serving on the Data Safety Monitoring Committee for the I-SPY 2 trial. She is an active member of Komen Advocates in Science, the National Breast Cancer Coalition, and the MBC Alliance. Liz has had the opportunity to work with Dr. Lin since 2006, often focusing on projects related to the supportive and educational needs of patients living with metastatic breast cancer. She is interested in increasing the capacity and effectiveness of patient advocates, as well as various issues related to clinical trials and evidence generation. Liz received her BA from Boston University in economics and a master's degree from the Harvard School of Education in Education Research and Program Evaluation. Liz, the floor is yours.
Hi, and I just want to thank you for including me in today's presentation. It's a privilege to be here and to be here with Dr. Lin. And it's my privilege as well to introduce her to you all. So with that, Dr. Lin is an associate professor of medicine at Harvard Medical School, associate chief of breast oncology at Dana-Farber, and director of the metastatic breast cancer program at Dana-Farber as well. She is co-PI of the DFHCC, that's short for Dana-Farber Harvard Cancer Center, NCI Specialized Program of Research, which many of you may know better as the SPORE. Dr. Lin has led multiple clinical trials testing novel therapies for patients with MBC, with a particular focus on those with cancer that has spread to their brain or brain mets. She has led national efforts to increase the inclusion of these patients in clinical trials. Dr. Lin has been involved in the development of several drugs which have become standard of care for patients with HER2-positive breast cancer, including those with active brain mets. She also leads the EMBRACE, which stands for Ending Metastatic Breast Cancer for Everyone, clinical and research programs at Dana-Farber. The EMBRACE research study, which has enrolled nearly 3,000 patients to date, enables multiple research aims, including genetic profiling of biospecimens from patients with MBC at diagnosis and at progression on each line of therapy in order to uncover mechanisms of treatment resistance, characterizing patterns of care and outcomes, and understanding patient-reported outcomes in the advanced disease setting. Dr. Lin's Komen-funded research is focusing on understanding resistance to antibody-drug conjugates in patients with MBC by determining the difference in target expression in genomic features after treatment. So with that, I'd like to invite Dr. Lin to come and begin her presentation.
Thank you, Liz. It's always
Sure.
such a pleasure to work with you. All right, let me share my slides.
Great.
Hold on. Let's see here. Okay. All right, well, thanks for having me today. And what I wanted to do today is to kind of give you a whirlwind tour of advances in metastatic breast cancer research and treatment 2022. So what we're going to cover today are the breast cancer subtypes, a few comments about germline genetic testing, tumor testing, and then delve deeply into advances in estrogen receptor positive metastatic breast cancer, triple negative MBC, and HER2 positive MBC, and then I'll make a few comments about clinical trials at the end. When we think about breast cancer, the way we treat breast cancer today is really subdividing breast cancer into three main subtypes. Estrogen receptor positive, shown in blue, is the majority of breast cancers, and these are cancers that are positive for the hormone receptor estrogen, as well as being HER2 negative. Another type of breast cancer is HER2 positive breast cancer. These cancers are positive for the marker called HER2, but they can be either estrogen receptor positive or estrogen receptor negative. And finally, triple negative breast cancers are cancers that are negative for all three of our main markers, estrogen, progesterone, and HER2, hence the name triple negative. If you're not sure what subtype of breast cancer you have, it's a really good question to ask your doctor, because this is really what determines the treatment options that are available. First, I want to make a couple comments about germline genetic testing. This testing is done either on your blood or sometimes on saliva, and it's really done to determine whether there are inherited genetic factors that you've inherited from your mom or your dad's side of the family that could increase the risk of cancer. Results of the testing could not only impact you, but also your family members. And certain mutations, specifically mutations in BRCA1, BRCA2, or the PALB2 genes, may open the door for a type of treatment called PARP inhibitors. So we do think it's very important that patients with metastatic breast cancer consider germline testing. In addition, we offer additional testing routinely for patients with metastatic breast cancer. This includes pathology review to look at important features, for example, whether this is a ductal or lobular appearing breast cancer under the microscope. We look again, as we talked about, at the receptor status, estrogen, progesterone, and HER2. And as I'll talk about later in today's talk, for HER2, we now have 3 categories, whereas before we had only 2 categories. So before we just called HER2 positive or negative, and now we call HER2 either 0, low, or positive, and I'll explain why in a few slides. Other markers we look at include a marker called PD-L1, which we look at specifically for people who have triple negative breast cancer. In some cases, we offer tumor sequencing, that is either on a tissue biopsy or on a blood sample. If it's on a blood sample, sometimes you'll hear it called liquid biopsy. And this is particularly important for patients who have estrogen positive breast cancers, where we're looking for mutations in a gene called PIK3CA. We're also looking at the number of mutations the cancer has, the so-called tumor mutation burden. We might be looking for reasons why the cancer has become insensitive or resistant to hormonal therapy. So for example, looking at the estrogen receptor called ESR1, and looking for alterations that might qualify for patients for specific clinical trials. For patients with triple negative breast cancer, we're looking at relatively fewer markers, but in general, as far as what's going to change practice, but we do look at the tumor mutation burden, and we're looking for alterations that might guide somebody to a specific clinical trial. And finally, with scans and physical exam, as well as review of patient symptoms, we're trying to understand the extent and size and location of disease. So now let's get into some details, and first I'm going to cover estrogen receptor positive, HER2 negative MBC. And the drugs I'm going to talk about today are one called trastuzumab deruxtecan, which is otherwise known as Enhertu, sacituzumab govitecan, otherwise called Trodelvy, and a medicine that's currently under consideration by the FDA called elacestrant. Now, there are a number of other targets and treatments, so I don't want to ignore them here. For patients who have BRCA1 or 2 alterations, there is a category of medicines called PARP inhibitors. There's immunotherapy for patients who have high tumor mutation burden, and there are a number of clinical trials that are trying to determine whether new hormonal treatments might work in patients whose tumors have developed resistance on the basis of mutations in the estrogen receptor gene. So this is kind of how we think about treating metastatic estrogen receptor positive breast cancer in 2022. In general, for most patients, we start with hormonal therapy plus a CDK4/6 inhibitor. And there are a lot of different combinations that could be considered because there are multiple endocrine treatments that we could use, and there are 3 CDK4/6 inhibitors that we can choose from. If a patient develops cancer growth on these medications, will then go on to additional hormonal therapy in many cases. And which hormonal therapy that is depends on whether the patient has a PIK3CA mutation, where we might favor alpelisib, or does not have a PIK3CA mutation, in which case we might favor everolimus. One of the medications that is potentially coming up soon is one called elacestrant, and I'll talk more about this, but this drug is currently at the FDA for review. Once patients have gone through the different types of hormonal therapy, we will often then switch to chemotherapy. But then what we would after that look for is whether the cancer is HER2 low. And so if a cancer is HER2 low, we might think about a medicine called trastuzumab deruxtecan, which is just approved by the FDA in August of this year. Or we might, after that, consider a medicine called sacituzumab, which again was just added to the NCCN guidelines in August of 2022. So these are very new treatments. And then after that, we might consider chemotherapy. And again, there's these other treatments that might come into play if patients have specific alterations like a germline mutation or high tumor mutation burden. So let's talk about antibody drug conjugates. So antibody drug conjugates, we abbreviate this ADC, are medicines where it's an antibody that finds its way to a specific protein on the surface of the cancer cell, and there is chemotherapy attached to it. And examples of these medications are Trodelvy, Enhertu, and Kadcyla. All of these are antibody drug conjugates. And what this shows is the antibody finding its way to a surface protein on the cancer cell. It's essentially swallowed by the cancer cell, and that releases the chemotherapy directly into the tumor cell. So there's very high concentrations within the tumor cell and lower concentrations in the rest of the body. An example of this is a phase 3 trial called DESTINY-Breast04. And this was a trial which compared trastuzumab deruxtecan, otherwise known as Enhertu, versus traditional chemotherapy in patients who had HER2 low breast cancers. And these breast cancers could be either estrogen positive or estrogen receptor negative. Patients had to have previous hormonal therapy. They had to have at least some previous chemotherapy for metastatic breast cancer, and their cancers could not be HER2 positive by the traditional definition. And patients received either, again, Enhertu or traditional chemotherapy. Just to show you what we mean by HER2 low, this is a tumor which the HER2 is the brown stain. You can see there's no brown stain here. For HER2 1+, there's some, and for HER2 2+, there's more right around the surface of the cell, but not strongly enough to be called a HER2 positive breast cancer. And so these two on the right, HER2 1+ and HER2 2+, would be examples of HER2 low breast cancers. And this can only be determined on a tissue biopsy. We can't use a blood biopsy or liquid biopsy to figure this out. Importantly, about 40% of triple-negative breast cancers and about 60% of estrogen receptor positive breast cancers are HER2 low. And so treatments that would be effective for HER2 low cancers would affect a lot of patients. And here are the main results of the study. On the left are results for patients who received the T-DXd, and on the right are the patients who received traditional chemotherapy. The way you read these plots is that every bar is one patient. The 0 line is where people start from. And if the tumor grows, the line goes up. And if the tumor shrinks, the lines go down. And you can see if you compare the two graphs that with patients on T-DXd, more patients had tumor shrinkage and very few patients had tumor growth. Whereas in patients receiving traditional chemotherapy, more patients had tumor growth compared to T-DXd and fewer patients had significant tumor shrinkage. And so overall, what the trial showed was that there are higher rates of tumor shrinkage, a longer period of disease control, about double, and longer survival associated with the use of T-DXd. And this has therefore become standard of care in patients with HER2 low metastatic breast cancer. And this is really new as of this year. Another antibody drug conjugate that has been looked at is called sacituzumab. Many of you know this drug as Trodelvy. And this was looked at in the phase 3 TROPiCS-02 clinical trial. This trial took patients with estrogen receptor positive breast cancer. Patients had to receive at least one previous hormonal treatment, as well as some chemotherapy in the metastatic breast cancer setting. And patients were randomly assigned either to get the sacituzumab or to get chemotherapy of choice. What was seen in the trial was that patients who received sacituzumab experienced a longer duration of cancer control, and they also experienced higher rates of tumor shrinkage and longer survival compared to patients who received traditional chemotherapy. And this information about longer survival literally was just presented at a September cancer meeting this year, and so it's really very new data. At this point in time, sacituzumab is not approved by the FDA for use in this particular situation. However, the drug is commercially available. It is available to prescribe, and it has been included in many of the national and international guidelines for treatment of patients with hormone receptor positive, HER2-negative breast cancer, and therefore can be prescribed even ahead of FDA approval. Finally, just a few words on this drug called elacestrant, which was looked at in a phase 3 trial called EMERALD. This trial included only patients who had hormone receptor positive breast cancer, and patients had to have received at least one previous hormonal therapy for their breast cancer. And as their second or further hormonal treatment, they either received standard hormonal therapy or they received the new oral medicine called elacestrant. And elacestrant works very similar to Faslodex or fulvestrant, which is an injectable type of anti-hormone treatment. And the way that it works is it causes the estrogen receptor to break down in the tumor cell, and therefore estrogen no longer serves as a fuel for the cancer. In this study, what was seen was that there was a longer duration of tumor control compared to standard hormonal therapy, and this effect was seen even as far as 1 year out, as far as the reporting. Overall, the effectiveness was quite good, including in patients whose tumors had mutations in the estrogen gene. But right now, there's not long enough follow-up to understand the impact on overall survival, and we'll have to see how patients do over a longer period of time. This drug has currently been submitted to the FDA for review, and so we presume that sometime in 2023, there'll be a decision about whether this would become an FDA-approved medication. Now, what about PARP inhibitors? And PARP inhibitors are used in patients who have mutations in the BRCA1 or BRCA2 genes that were inherited from their family. And these drugs, oral drugs, are not chemotherapy, but they're targeted therapy. And they were looked at compared to conventional chemotherapy in 2 phase 3 trials. The trial on the left, called Olympiad, used the drug olaparib, and the trial on the right, Embraca, looked at the PARP inhibitor called talazoparib. In the blue is the tumor shrinkage rate with a PARP inhibitor, either with olaparib or talazoparib. And in the red is the tumor shrinkage rate with regular chemotherapy. And so you can see, obviously, that there is significantly higher chance of tumor shrinkage with a PARP inhibitor compared to traditional chemotherapy. And based on these data, it's really critical to obtain germline testing, again, that's on either blood or saliva, in patients with metastatic breast cancer to see if you could be a candidate for a PARP inhibitor. In addition, there is some data that the PARP inhibitors might work even in patients who have other types of mutations, and one in particular is a mutation called PALB2, P-A-L-B, the number 2. And in this study, where 13 patients with PALB2 inherited mutations were enrolled, actually 9 out of 11 patients had significant tumor shrinkage, and 10 patients in total had some degree of tumor regression, and 1 additional patient had stabilization of her tumor for more than a year. So this is very high activity level for this very specific type of patient. And these data apply to both estrogen positive as well as triple negative metastatic breast cancer. Another marker that we look at is something called tumor mutation burden. And again, this applies to both estrogen positive and triple negative breast cancer. In this study called TAPER, what happened is that patients who had a high tumor mutation burden, and this was based on testing of their tumor were enrolled in a clinical trial where they received a immunotherapy on its own without any chemotherapy. And what you can see is that there were some patients shown here on the right that did experience significant tumor shrinkage with the use of immunotherapy on its own. And in some cases, these responses were very long-lasting. And so this is an option for patients who have high tumor mutation burden if they have ER-positive or triple-negative disease. So I hope I've been able to show you how much things have really changed over really the last year or so in patients who have estrogen receptor positive metastatic breast cancer, where we're really using a number of new drugs that we had not had access to before. So there are more options than before. This also requires more testing to make sure that patients are aware of the options that could be available to them. And one of the questions coming up is, what is the best sequence of these new treatment options? Because we don't really know for sure yet if it makes a difference to go to one A versus B then C, or C versus A then B. And these are things that we're going to be trying to work out over the next few years. And there are many ongoing clinical trials across all lines of treatment. Now moving to triple-negative breast cancer, here I'm going to focus on a couple of drugs, including Trodelvy and Enhertu, as we had talked about before. I'll also say a few words about chemotherapy plus immunotherapy for patients whose tumors are so-called PD-L1 positive. And I won't have time to get to it, but there are new antibody drug conjugates that look very exciting for triple-negative breast cancer. So this is how we used to treat triple-negative breast cancer, and this is, maybe 3 to 5 years ago, this is exactly what we would do not that long ago, which is that we would just give one chemotherapy after another. But today, it's much more complicated because as the first chemotherapy treatment, we want to know whether a patient is PD-L1 positive. That determines whether or not immunotherapy would be helpful, or if they're PD-L1 negative, in which case most patients receive chemotherapy, except if a patient has a germline BRCA1 or 2 mutation, where we might give a PARP inhibitor instead. After that first line of treatment, there would be options of sacituzumab or of the trastuzumab deruxtecan or Enhertu, and flip to the vice versa if patients hadn't received them before. And then only in the third line and beyond are we then thinking about one chemotherapy after another after another. So let's go through the data. The first is this phase 3 trial called KEYNOTE. This trial took patients who were and randomly assigned patients to either pembrolizumab, which is an immunotherapy plus chemo, or chemotherapy without immunotherapy. And how immunotherapy works, in general, when we say immunotherapy, we're really talking about medicines that block something called PD-1 or something that blocks something called PD-L1. And the way that this works is, if you think about the immune cell shown in blue, it finds its way to a tumor cell because it finds the tumor cell showing something that is foreign to the body, and so the cancer cell, the immune cell knows to attack it. But then the tumor cell actually turns the immune system off with this little switch. And if you block either PD-L1 or PD-1 with these drugs, you prevent the off switch from happening, and therefore the immune cell can still be active to get rid of the tumor cell. And so you can think of this as an on-off switch. And so when you add in the immunotherapy, the immune cell basically is kept on. And this theory was proven in this clinical trial. So first, what they looked at is, what is the chance of tumor shrinkage in patients who got the immunotherapy added to the chemo versus the patients who got chemotherapy alone. And what was seen is that in patients with PD-L1 positive cancers, there was a higher chance of tumor shrinkage. In addition, there was a longer time of tumor control and an improvement in overall survival. So for patients who have PD-L1 positive cancers, we're typically starting with chemotherapy plus immunotherapy. Another trial that was very important is called the ASCENT trial, and this was a phase 3 trial that looked at patients and compared sacituzumab or Trodelvy versus traditional chemotherapy. In this trial, patients had to have some previous chemotherapy for metastatic breast cancer before they were allowed to enroll on the study. And the patients were assigned to either sacituzumab or chemotherapy. And this is the highlighted results of the study. If we look at the average time to cancer worsening, it was much longer in the sacituzumab, shown in blue, compared to the chemotherapy, shown in red. And the average survival was also longer in patients who received sacituzumab versus those who received chemotherapy. It's important to note also that these averages are just that, they're averages, and that means there are patients who went out far longer than the average, and it's not that every patient is going to have a problem at the time these blue bars stop. And what about Enhertu? And I showed you data for estrogen receptor positive breast cancer, but what about patients who have triple negative breast cancer? So this is the same study. And in that same study, there were 63 patients who had triple negative HER2 low breast cancer. And again, what you can see is that patients who received the T-DXd or Enhertu had a longer, more than double period of time before the cancer worsened, and also a significantly longer survival. And so although these numbers are small, in fact, the FDA did provide an approval for use of trastuzumab deruxtecan or Enhertu in HER2 low patients, irrespective of the hormone receptor status. So just to go back to the summary slide, for triple negative breast cancer, again, everything has gotten quite a bit more complicated. That's a good thing from a patient standpoint because there means there are more options that are available. And really the ones to highlight are these options of the sacituzumab, the Enhertu, the immunotherapy, the PARP inhibitors, which all really are relatively new, kind of hot off the press. So for triple negative breast cancer, again, need for more testing. So we do like to routinely test for PD-L1, germline genetic testing, HER2 low status, and tumor mutation burden. And similar to my comments previously, there are many ongoing clinical trials to test even newer treatments in patients with triple negative disease. The final topic I want to cover is HER2 positive metastatic breast cancer. And here I'm going to focus on two drugs in particular, Enhertu or trastuzumab deruxtecan and tucatinib. I will note that there are a number of additional options that are available, which we won't have time to talk about today. And these include margetuximab, which we give in combination with chemotherapy, as well as a 3-drug combination of trastuzumab, fulvestrant, and abemaciclib, based on a phase 2 study. And there are a number of HER2-targeted drugs currently in clinical trials. So here's the design of the DESTINY-Breast03 study. This was a phase 3 study in patients with HER2 positive by the traditional criteria, so HER2 3+ or FISH positive. And these patients had received a previous treatment with some sort of taxane, like Taxol or Taxotere, or Abraxane in combination with trastuzumab, otherwise known as Herceptin. And patients were randomly assigned to either T-DXd or to the previous standard of care, which was T-DM1. And this is what was seen in the study. So again, as a reminder, every bar here is one patient. And you can see with T-DXd that almost every patient had some degree of tumor shrinkage, as compared to patients on T-DM1, where it's more evenly split between patients who had tumor worsening or similar tumor size versus those with true tumor shrinkage. In fact, in patients treated with T-DXd, 80% had significant tumor shrinkage. There was a longer period of disease control, and there was also a trend to longer survival, but there's not enough follow-up data yet to be sure of this finding. So the FDA approved T-DXd in May of 2022 for patients who had received at least one previous HER2-targeted treatment, or those patients who had disease recurrence within 6 months of finishing their early breast cancer treatment. One of the important findings from this year is that T-DXd or Enhertu might also work in the brain. And we didn't know this before because the phase 3 trials did not allow patients with active cancer in the brain to enroll. But subsequently, there have been several studies. They're small studies, but they do show tumor shrinkage in the brain. And again, each bar is one patient. This is a study from Europe showing significant rates of tumor shrinkage in the brain. And this is a US-based study, again, showing the same thing. This is an example of a patient treated at our institution with T-DXd. This area did not receive focused radiation. It was treated solely with the Enhertu treatment, and you can see a very significant tumor shrinkage in the brain. So there is a global trial now called Destiny Breast 12, which is enrolling up to 250 patients with brain metastases who have HER2-positive breast cancer to see whether these findings can be confirmed. And then I want to talk about a trial called HER2CLIMB, and this trial looked at a medicine called tucatinib, which is an oral HER2 blocking medicine. The trial included a placebo, but it's important to recognize that all patients in the trial received trastuzumab and all patients received capecitabine chemotherapy. So this is a trial comparing tucatinib plus a traditional chemotherapy Herceptin backbone versus Herceptin plus chemotherapy. And what was seen in the study was that adding tucatinib to trastuzumab and capecitabine resulted in longer period of disease control, a higher chance of tumor shrinkage, and longer survival. Importantly, this study, in comparison to the T-DXd trial, allowed patients with brain metastases, including those with active brain metastases, to enroll. And these same findings, better disease control rates, longer period of disease control, better chance of tumor shrinkage, longer survival, were also seen in the group of patients with brain metastases. So where are we now for HER2-positive breast cancer and in metastatic breast cancer in general? I think we've seen really important recent treatment advances in all three major subtypes, and the pace of progress is faster than ever before. Still, we know that there's a lot of progress left to be made, and that segues into my final comments about clinical trials. Clinical trials may be available at multiple points along the way. They're not just the last resort, so to speak. And at least for metastatic breast cancer, there really are no trials that compare new treatment versus no treatment. So there may be trials that include a placebo, but in those trials, patients who receive placebo also generally are going to receive standard of care treatment. So here are the phases of clinical trials, starting from phase 1, which are really trying to understand what's the right dose to give and the safety profile. Phase 2, which we're starting to understand a little bit better what's the effectiveness of the drug and a little bit better understanding of the side effect profile to try to understand whether we should pull a drug into phase 3. The phase 3 trials are almost always randomized trials where patients either receive standard of care treatment or the new treatment, and they typically include several hundred patients. And finally, what are some questions to ask your oncologist? I think one of the most important questions is what subtype of breast cancer do you have? Why is your oncologist recommending a specific treatment for you? What are the anticipated benefits and side effects? An increasingly important question is whether there's any other testing you should have done right now, either on your tumor or genetics or tumor genetics, to try to understand both current and future treatment options, whether there's a clinical trial option, and finally, if there are any other ways, if you're interested in contributing to research beyond clinical trials. So thank you very much for your attention. I'm happy to take questions.
So thank you very much. That was a wonderful talk. And I'm going to start with a couple of the questions that have come in so far, but I would encourage other people to please put your questions in the chat and we will get to them as quickly as we can. So the first question is Elastrant an option if you've already progressed on fulvestrant? And can you explain why?
Yeah, so right now it's not an option commercially available to anyone because it's not available outside of clinical trials at the moment. If the FDA has a positive opinion and the drug becomes commercially available, then yes, it would be an option for patients who've already received Faslodex or fulvestrant. I would say that probably if it does get approved, we might use it in place of fulvestrant because fulvestrant, as you know, is something that requires intramuscular injections. It's not so comfortable, it requires people to come back to the clinic frequently, whereas elacestrant is an oral pill. So I think what is probably going to end up happening is it will be used in some cases in place of fulvestrant rather than after.
Okay, and do you have any sense of what the timing is with the FDA
It should be sometime
approval
within,
process?
yeah, it should be sometime within the first half of 2023.
Okay, so the next question is, how bad are the side effects of Enhertu and Trodelvy? And maybe when you're talking about that, you could talk a little bit about um, how are the toxicities from ADCs different from those that are from our more standard chemotherapies?
Yeah, it's a great question. And I think that when I counsel people about either Enhertu or Trodelvy, I tell people that it's going to feel like chemotherapy because it does. The hope was that because these are, smarter medications and they deliver the chemotherapy in a more targeted way, that they would have fewer side effects. Now, it does have fewer side effects than if you were trying to give straight IV drug, and trying to get the same drug levels in the tumor. Yes, it definitely has less side effects than that. But they still do have chemotherapy-like side effects, so they can cause low blood counts, nausea, vomiting, fatigue. There is a rate of hair loss. The majority of patients do not lose their hair with these medications, but about 30% do. And one of the things that I try to do is to first make sure that people have the right expectations about what this is going to feel like, to make sure there's a good open line of communication so that we can deal with symptoms if they come up, to be very proactive about pre-medicating for nausea, which can be quite problematic with these medications, but is usually very responsive to anti-nausea medicines. And then to have a low threshold to reduce the dose a little bit if patients are running into problems.
Okay. Can you talk a little bit about what happens when treatment stops working? What are the various things you do as a provider?
Yeah, it's a great question. And so, the reason, at least in 2022, that in general we don't think we can, cure metastatic breast cancer in most patients is because eventually each treatment stops working and we have to go from one to the next to the next. And we don't always understand why treatment stops working. I mean, that's a really big field of research, just to try to better understand why this happens. But even without necessarily understanding exactly why it happens, we do have to have a plan of action for patients as to what we're going to do next. And this is where I think having kind of so-called ducks in order is very good. So in somebody who has estrogen receptor positive breast cancer, in general, I'm going to start with hormonal therapy plus a CDK4/6 inhibitor. And I don't need lots of special testing to tell me that that's what I'm going to recommend, other than the usual scans and blood work. But what I try to do in that situation is to ahead of time test the patient's tumor for the tumor genomics, and then also to make sure they've had germline testing, because I want all those ducks to be in order when the cancer gets worse again. So I don't have to scramble, and the patient doesn't have to scramble to get those results when the cancer is getting worse. We already have those results in hand. We might supplement it with an additional liquid biopsy at times, but in general, we have what we need to come up with the next type of treatment. And so I think it's always a good question to ask your oncologist, if this doesn't work, what would I do next? And, they should be able to answer with a couple of different options of what they're thinking at that moment, understanding that it could change as new treatment options become available in the future.
So thank you, Nancy. Can you talk a little bit about what you tell patients who come in with a BRCA mutation in terms of not only not maybe their treatment, but also if they have daughters and sons, what might be indicated for them?
It's a really good question. So when we do genetic testing, you can get a result that, for example, says that there's a harmful BRCA mutation. Sometimes we also get results that just say it's a variant of unknown significance of US, and those we actually do not do anything differently for, but we really only consider the ones that are considered harmful. And there's about a 50-50 chance of passing on to both sons and daughters, and they have implications as far as cancer screening. In general, the good news is we don't generally see pediatric cancers in BRCA carriers. So we don't see like cancers at age 16. So for the most part, we really believe that patients, at least for BRCA1 and 2, can wait until they've reached, adulthood to have testing. At the same time, we generally are not recommending that people wait till they're 40 to be tested, because we would generally start screening earlier if we knew that the patient or the son or daughter had a BRCA alteration, especially if they're a daughter and we're screening for breast cancer. For males, right now there's not a lot of additional screening we do. There's a little bit more attention to prostate cancer because it's more common in BRCA carriers, but it's important for their children as well. So it's important for testing for that reason. And there are some studies to see whether or not BRCA carriers should have screening for pancreas cancer, for example. And so it is useful to have sons tested eventually as well. But again, we don't generally recommend it until offspring reach adulthood.
And are these kinds of programs available in the community, or do people have to go to sort of larger, more academic medical centers to be screened for these kinds of things?
They are available through the community. I mean, I think best case scenario is still to have the testing, with a genetic counselor, to have some counseling around the testing, both pre and post. But that's not always available, and I wouldn't want people not to get tested because they couldn't access a genetic counselor, for example. If a test comes back positive, that would be a reason, if you have not had a chance to meet with the genetic counselors, to go ahead and do so, because the interpretation of the testing can be quite complicated, and we don't want to be, you want to make sure that you have the right information, and that's going to be really helpful to see either a genetic specialist or genetic counselor if you have a positive test.
Okay. So the next question asks about dosing. So the question is, what are the options for reducing the dosage for Enhertu and Trodelvy? And is it possible to start low and increase versus starting, this person asked starting high, but I would say starting at maybe you could talk a little bit about where you start and what the label means.
Yes, so the way the clinical trials were done is that everyone in the trial started at the same dose. And then in the case of, I'll just give the case of Enhertu, there were 2 so-called dose reductions allowed, meaning there were 3 different levels that patients could be on. The normal starting dose, 1 dose level down, and 2 dose levels down. And the same is true of Trodelvy. And in the trials, in general for clinical trials, overall, if you look, the way they're analyzed is according to what group the patient was assigned to from the beginning. And when people have tried to look at, do patients who have needed a lower dose do worse or not worse? Generally, the answer is patients who needed to lower the dose did just as well as patients who were able to stay, on the full dose. What we don't know is if you start people at a lower dose to begin with, because they didn't have side effects, you just start them at a lower dose, whether they would do equally as well. I think in general, we feel like that's probably true. And so my practice is that if somebody has tolerated chemotherapy well in the past, blood counts are okay, they're pretty active, I usually start people on the full dose, but with a low threshold to reduce if there's side effects. If I'm worried about somebody, I'll start either the medium dose or the lowest dose, and that's going to depend on how active they are, how functional they are, what their other health problems are, what their blood counts look like. But I have no problem starting people at lower than the usual starting dose if I'm worried.
Okay, so because you've had some not so hard questions, here comes a doozy.
Okay.
What causes the cancer cells to start growing again, sometimes years after no evidence of disease?
Yeah, this is a really good question. And it's a really good question both in metastatic breast cancer, where patients can go to NED status and then come out of it for reasons that we don't understand. And also patients in the early stage setting, where sometimes, especially for estrogen positive breast cancer, somebody might have an early breast cancer and not until 10 or 15 years later have a recurrence of the cancer. And we don't think that the cancer could have been actively growing at an equal speed the whole time. Otherwise, it wouldn't take 15 years to show up. I'm afraid I don't have an answer to that question, other than we don't know the answer to that question, but it is a very, very active area of research because of how important it is both in the early stage and metastatic settings.
Okay, thank you. So while we're waiting for other questions, I'm going to ask you a question, which is, many of the advocates that I work with believe that screening for brain mets should be part of standard of care for patients newly diagnosed with metastatic breast cancer. And can you kind of weigh in and talk to us about your thoughts on this and what the evidence is in breast cancer and in other diseases?
Yes, it's a really good question. So what we know at this point is that among the subtypes of breast cancer, patients who have either HER2 positive or triple negative breast cancer have a higher rate of developing brain metastases at some point in their disease compared to patients who have estrogen positive cancers where the rate is about 10 or 15%. It is a lot lower. In general, for all patients, if somebody comes to me with concerning symptoms, and actually the most common symptom is headache. It's not weakness or seizure or other things like that, although those things can happen. It's usually some difference in the pattern of headaches potentially associated with nausea, vomiting that wasn't there before. And in that case, I have a very low threshold to do an MRI of the brain because I don't want to miss a brain metastasis. This idea of screening patients who don't have any symptoms and just sort of routinely doing scans is something that's controversial. And the guidelines have kind of evolved a little bit in the sense the original ASCO guidelines, it's our national organization, originally made a recommendation against screening. The most recent version of the guidelines actually just says that there's no data to support for or against. So it's a less strong statement, right? Because the truth is, there's a difference between saying there's no data to support something because there's a big trial that says it doesn't work versus there's no data to support something because there is not a trial that has been done properly to ask the question. And unfortunately, that's the case. There's not been a large enough trial done to answer the question. If somebody is going to think about having MRIs done, one thing that's important to think about is the timing. And so you don't really want to do it like every 6 months on a random basis, I think, because that means that maybe you switched your systemic treatment 2 months ago and then you randomly have a scan and you don't really know at that point if something that is found is actually getting better on your current treatment or not. So I guess what I would say is I generally have not routinely offered the screening. When I've done it, it's really been kind of at the time when patients have worsening of their systemic cancer, so that at least we know that we're going to make a treatment switch. We can help to inform the next treatment decision. Or sometimes I'll do it if a patient has rising tumor markers and their normal scans are fine, because I'm trying to see like what's explaining, the rise in tumor markers that is something outside of what we're looking at normally.
Okay, thank you. So this is a question that's a little bit more specific, but maybe we can answer it in a more general way. This person had a recurrence after 29 years and now has cancer on their lymph nodes and skin. The question is, have you addressed any TNBC trials that might address this or treatments? And then I would broaden the question actually to say, if a patient is looking for a trial and has a specific situation, how do you suggest they actually go about trying to figure out if there's something that would be suitable to them?
These are great questions. So there has been an interest in the so-called chest wall disease or disease that shows up in the skin primarily. And there have been over time some clinical trials here and there that have addressed that specific group of patients. There's a trial that is being done by the Translational Breast Cancer Consortium looking at immunotherapy for those patients. There has been a previous trial looking at medicines that sensitize to specific wavelengths of light, and then you put this like light patch on the skin nodules to see whether that might be helpful. And so there's been a number of studies. They're limited studies, but there have been a number of studies specifically looking at chest wall or skin disease. But the larger question of how to find clinical trials, I think that, there are a number of different ways. There's, of course, websites, and of the websites, I think MBC Alliance has a very nice web finder where you can put in the type of breast cancer you have, the subtype, the geographic distance you're willing to travel for a study, and outcome, a listing of trials. So that's one way. But ultimately, at the end, I think to sort through the options, you really need the help of an oncologist, because otherwise, you come up with many, many different options. And I think it's really helpful to have somebody say, okay, of all the different options that are available, this is the one that I would bet on. and we don't know because it's a trial. If we knew for sure it's going to help, it wouldn't be a trial anymore. It'd be a standard FDA-approved therapy. But I think that kind of getting someone's gut feeling is really important. Many people are treated in the community. That's the most common place that patients in the United States with cancer are treated, is not at a large academic center. But community sites, many times, not always, many times community sites do not have the same access to clinical trials. There are actually some community networks have very good access to trials because they've got these big consortia and they're sort of part of a lot of trials. So it's not always the case that community trials don't have trials, but in general, on average, they have fewer than academic sites. So if you're seen at a local oncologist's office, you may want to, travel to your nearest academic cancer center, NCCN designated cancer center, to learn about clinical trials if it's something that you might be interested in, because they would be able to then network and find other trials for you.
Thanks. I think it's nice to know that it's not an expectation for a patient to do this on their own.
Absolutely. I think it's really hard to sort through. It's really hard. And I think the search engines, none of the search engines are perfect because they, many of the trials have very complicated criteria of who is eligible and who's not eligible. And so that just X's trials out right off the bat. And also, I think that your oncologist may have information. I don't mean this insider trading information. I mean just information about, information about the mechanism of how the drug works and what the phase 1 data look like that are not published yet, but have been presented at a meeting in some format, that they can help kind of you prioritize between one trial and another.
Great. So our last question is really, so out of the current research for metastatic breast cancer, what treatments or technologies do you see as most promising and why?
That's a great question. I think cross-cutting across all the different subtypes, the category of medicine I think is the most interesting are the antibody drug conjugates, because it takes a general principle, which is find some target that's on the surface of the tumor cell more than on the surface of normal cells, attach some treatment to it, and get it into very high concentrations. And that principle we've seen work in all 3 major subtypes of breast cancer. And there are many ADCs that are in development with different targets and different drugs attached. And it's kind of like a modular mix and match approach. And I think there's a huge amount of promise in those kind of ADC type approaches. The other area I think that's really of interest is immunotherapy, because right now, only a small sliver of patients with metastatic breast cancer benefit from immunotherapy in breast cancer, that is triple negative PD-L1 positive. But we see in other tumors that immunotherapy is widely effective. We just haven't quite hit on the right formula for breast cancer. And I think that's where the clinical trials are so important, to see whether we can figure that out. Because if immunotherapy works, the beauty of it is that the immune system can evolve with the cancer. And so when the cancer becomes resistant, the immune therapy can follow. And that's really different from all the other chemotherapy drugs where you give the exact same chemical all the time, no matter what the tumor is doing. So I think if we can better figure out how to use immunotherapy, that would be a huge advance, but we're not quite there yet.
Okay, thank you. That's very helpful. So I wanted to say thank you so much. I learned a lot. I'm sure our audience did. And to the audience, I want to just say I'm sorry we couldn't get to everybody's questions. But we did the best we could, and I'm going to pass it back, I think, to the people at Komen to wind this up.
Yes, ma'am. Thank you both very, very much. We're so excited that you both and everyone today could join us for this event. So I want to take just a moment again and say thank you, Dr. Lin. Thank you, Liz Frank, for this riveting discussion. Today's session was recorded and will be posted on our landing page soon, so you can rewatch this session or view whatever previous sessions are of interest that you may have missed. Please help us spread the word about this important content with your friends, family, healthcare professionals, anyone you think that might be interested in learning more about metastatic breast cancer. Once again, we want to acknowledge our sponsors of the 2022 MBC Impact Series. Their generous support allows us to continue to bring this community together to share important information, resources, and experiences. A very special thank you to AstraZeneca for being the technology sponsor for this year's events. We would also like to thank our premier sponsors, Amgen and GE Healthcare. Our signature sponsors as well, Walgreens, Sanofi, Daiichi Sankyo, and Merck. The series is made possible because of their generosity. Please also help us by completing a survey, which you can now find in the chat feature of the platform. Your feedback is very important and does help future MBC program planning. And by completing the survey, you'll be entered to win a $25 Amazon gift card. Finally, the next event in the MBC Impact Series will be on November 16th. The focus of the conversation will be complementary and integrative therapies. So we look forward to having you log in and join us. Thank you again for joining today, everyone. And thank you to all who made this event possible. Stay safe and stay connected.
Thanks all.
Thank you.